Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed by anybody.
Okay, so I hope you can hear me fine, guys, and I begin today's class. Let me share the screen so that you all can see properly, and we can go ahead from here. So, all right, though we have we don't have much people right now, but still I think they'll join in. And before I start the class, I had sent a couple of things on the Telegram channel, my channel, last night, and I expected people to read it through because that's very, very important regarding Plan A, B, and B plus of WHO, not just WHO, also accepted by NAP. Tonight, the class is going to be on HIV in pregnancy, and I have made sure that I always, take first the Indian guidelines, and then maybe if it's not available, then go in for the European guideline or the American guidelines. Why I do that is because we as Indian people have a typically different climatic conditions, geographic conditions, biological conditions, our growth potential, BMR, everything is very different from what it is. And of course, we are a low resource setting, not to not mention that, a developing nation. So everything which might be a recommendation or a guideline abroad might not work very well in Indian scenario. So I always go ahead first for the Indian guidelines and then maybe the European or the American systems. So good evening and welcome everybody to my class today, and it's going to be on HIV in pregnancy. I hope you people have already read the two messages I sent earlier on my Telegram channel. They were about the Plan A, B, and B plus of recommended now by WHO and also incorporated by NACO, which is an Indian association, and we go ahead and study their recommendations in tonight. The class on HIV. So we go ahead and endorse and accept and imbibe all those recommendations given by WHO and then by NACO, and then go ahead and devise a plan for the pregnant patient who is HIV positive. So let's begin tonight the class on HIV concerning everything in minute detail about HIV virus, which is a very, very important virus, and your exam has multiple times in different ways asked this question about HIV. I hope I'm loud and clear, and if you're feeling that there is any disturbance in my class, please go ahead and tell me. If you're not able to see the screen properly, please be frank and let me know if there is any kind of problems. Now, we begin with the introduction of HIV, which is an RNA retrovirus, and it causes very serious infection, which in about 8 to 10 years. Now, this is the good thing about HIV infection, that it takes some time to develop, and by some time, I mean 8 to 10 years or even more. Okay, and if the immunity initially to start with was good, then it will take even more time to grow into full-blown AIDS. We are going to be discussing that later in the chapter. So, which is obviously by acquired immunodeficiency syndrome. It's an immunodeficiency syndrome. How it happens, we're just going to discuss about it, the pathogenesis, in which the immune system is so depleted that unusual bacteria and the viral infections, they start attacking our body, and we finally succumb to those infections. So let's just a brief view of what is the epidemiology. So HIV is increasing in all countries. It's a global problem that we know. We have the latest, statistics of 2012 by WHO, and according to that, there were around 35.3 million people who were infected with HIV, amongst which 50%, which is a good figure, was the females. And there is a reason why so many females are infected with it, not just because they're cohabitating with those males who are HIV positive, but also the fact that females, they require a lot of blood and blood products during some point in their life, because they bleed during the delivery or due to abortions, or because of so many reasons, ectopic pregnancy, sometimes septicemia, sometimes illegal abortions, that they have the requirement for blood products is more in females as compared to male. And you know that this is a blood-borne disease. It's either through drug abuse, or through marriageous route, or through blood transfusions, and of course through sexual intercourse. So because of that, a huge population of females are already infected. And when you talk about India, India has the highest population of HIV infected persons, next only to Africa, which is a very alarming figure. And amongst this also, if you talk about Indian subcontinent, you'll see the southern part, Maharashtra, Andhra Pradesh, Tamil Nadu, Karnataka. These places, they bear mostly the burden of HIV in the country. Around 62% of the entire HIV infections, they're seen in these 4 states, which I just mentioned. Okay. So with this scenario, we go ahead discussing the risk factors and modes of transmission. So you know it very well. We've been discussing, this was a thing of your undergraduate level. How is it like, what is the risk factor? So these are the risk factors. Blood transfusion, promiscuous behavior of either partner would lead to more of HIV because it's a sexually transmitted disease. Illicit use of drugs, drug abuse, which is not so much obviously in females. We're more concerned about, because gynecologists here talking about females mostly. So we're more concerned about why 50% females are still harboring this infection. And this is basically, these are a couple of reasons which I see. Indulging in unsafe sex practices, and obviously this promiscuity is very, very important. A brief word about etiology and pathogenesis. So here you'll get to understand the next, slide. So this is the basis for the next slides to come. So please watch this carefully. Have a look at the structure of HIV virus over here. Amongst, when you're talking about the outside, the outer coat, do you see GP41, which is a transmembrane glycoprotein, GP120, which is a docking protein, okay? And then you have internal, this matrix protein is there and on. You have everything inside, then you have a capsid outside, okay? Then you have an envelope, a lipid envelope. And inside what you see is, you see a matrix protein, then you see this whole thing, this nucleocapsid is there, RNA genome is there, integrase is there when you talk about integrase inhibitors, fusion inhibitors. So over here you have reverse transcriptase inhibitor. So these are all enzymes which make it more lethal, and every enzyme has its own function, and that is not expected of you at this point in time to describe each and every cellular structure of HIV. That question is not expected out of you. What is expected out of you? We have a class on that today. So HIV is a retrovirus. Either you can see the diagrammatic structure. What happens is that it's a very smart virus. It integrates within the host genome on the infected host cells, and it produces multiple copies of the HIV genome as DNA. I think you must have heard this very often about the bacteriophage doing this. So it goes and it integrates with the human genome, and then it makes these couple copies, of the HIV genome actually. And the target of this virus are what? The helper, the CD4 helper lymphocytes, which start producing new virus particles, and they themselves, they lose their central role in the immune response to fight the various infections. So are you getting me? So what's happening is that the best, lymphocytes of the body, the ones who are very good in adaptive immunity, they are targeted. Once they are targeted, these, helper lymphocytes, they are the ones who lose their actual job and start doing some other job. Now they started producing bacteriophages, or let's say, the HIV genome, rather than concentrating on the main job to fight for the body. So the immune response has gone down. And now the CD4 lymphocytes are doing another, role. That's the basis of HIV, because of which so many opportunistic infections finally lead to the catastrophic, full-blown AIDS or the terminal picture of the AIDS patient. So basically, HIV causes progressive immunosuppression and ultimately the development of full-blown AIDS. Now, let's see how it progresses. Again, this is also very, very important. So please be very careful. When I am explaining you something that forms your basics, I go very slow. So please try to understand what I'm trying to tell you over here. First is the incubation period. Okay, so the moment you contract AIDS, there'll be an incubation period like in all diseases, but here you have it for 1 to 3 weeks. Okay, in this case, you will have nothing coming positive. Definitely not the antibodies. Antigen is also query, right? But they do say that, this GP24 antigen of virus, the HIV virus, starts showing between, some 10 to 28 days. That is the, long period of uncertainty when the antigens start showing positive. After exposure to the virus infection, then there comes a window period. Then there was a incubation period, then comes a window period. Now this window period is also pretty long. It's for 12 weeks, 3 months. Here, important thing is that antibody titer is not detectable. Okay, so the antibody titer in the window period is not detectable, and mind you, all the HIV tests that you've known of, the ELISA test, the rapid test, they're all dependent upon the antibodies, not the antigen. Okay, so these tests will also come negative. So that means now we spoke about 3 weeks, then we spoke about 12 weeks also. Okay, so straight away for 4 months, nothing is coming positive, despite the fact that you've already contracted HIV. Then comes a stage of primary infection, which is highly infectious, and with the CD4 cell count being near normal. So if you start showing, fine, okay, HIV has happened, we can't see the antibodies, but let's go for seeing the CD4 cell count, because it will be attacking the CD4 cells, right? So they'll go down, but even that does not change. Okay, so till you've reached the primary infection, but CD4 cell count still is maintained. Then comes an asymptomatic but infectious period. You had an asymptomatic period before, but now we have an asymptomatic infectious period, which is for 3 to 5 years with detectable antibodies. Now you can see the antibodies. For a period of, let's say, 3-4 months, you had nothing to show. Okay, you contracted HIV, but you did not have any test to show that there was actually you were contracting or you had HIV. So it's asymptomatic but infectious period in which you will have detectable antibodies, which will show in ELISA test, which will show in your, which will also show in your rapid tests, those kits of HIV. Then we talk about early immunodeficiency. As the name suggests, here the CD4 cell counts start decreasing, but they are always above 500 cells per microliter. Remember this figure of 200 so 200 copies or 200 cells per microliter. That's your cutoff for severe, severe AIDS. So 500 and above is okay. Then there is an infectious period, again for 2 to 3 years, with subtle symptoms and signs of immunodeficiency. So here again you have CD4 cell count decreasing further. So it comes between 200 to 500. And after another 1 to 2 years, there is full-blown AIDS with symptoms and signs of opportunistic infections. This is where most of the people, they succumb to HIV. Okay, you're trying to hold one thing, the other thing goes down. You're trying to, hold on to that thing or improvise that thing, and the other thing goes down. So your body is undergoing so much of trauma through so much of infections, and very dangerous infections, because there is no fighter mechanism inside your body. So you're falling prey to every next opportunistic infections, we call them, because they got an opportunity to flourish, otherwise they wouldn't have. Okay, and you're falling sick to all those things. Finally comes the terminal illness, when the CD4 cell count becomes 200 cells or less, and that's, probably the end of it. So this is, it takes around 10 years or more for the full-blown AIDS to take place. So we have this 10 years window period in which we can help the patient. That's the idea which I wanted to tell you. Now, modes of transmission, I've already told you: sexual, parenteral, vertical. So our concentration is going to be on the, the vertical mode of transmission, because we want to decrease that from mother to child. So placental transfer is around 20%. That is, I'm talking about antenatal. Intrapartum it goes high as 50%, and postpartum it continues if there is breastfeeding, so 30%. Okay, so maximum you see is in labor or intrapartum. Now, talking about the risk factors for vertical transmission. Now, just imagine that if a patient asks you that, fine, I am HIV positive. Fine, I know that there'll be some amount of transmission to my baby. But can you tell me what are those conditions in which, there'll be more transfer of infection? I want to cut it short as much as possible to the baby. So what should I do? So the reason is that you have to keep the viral load as low as possible. How is that possible? By taking the antiretroviral drugs consistently. We'll get to that later on. So you have to, increased viral load is, the more the viral load, the more it will be transmitted, right? That the more virulent the strain, the more virulent, the more, it will be passed on. The more you have, suppose you have another partner who's HIV positive, the more it gives you the, the load, the more it will be during pregnancy. if you start having, I mean, you'd be foolish enough to do illicit drug use. But yeah, CD4 cell count, very important again. In fact, it's one of the most cornerstones when you're deciding for the amount of ARV to be given, how long to be given according to Plan A. CD4 cell count happens to be very, very important factor. Okay, so if your CD4 cell count is very low, no matter how much ARV you take, you are going to transmit the infection very high to the baby. And then, of course, the more handling you have, the more invasive procedures you have, rupture of membranes have happened more than for 18 hours, it's definitely going to go. Then what is the mode of delivery? Was it instrumental delivery? Was it, that agitated, prolonged labor delivery, instrumental delivery? You have more chances of passing the infection to the baby, because intrapartum, that means in labor, there are 50% and even more chance, right? Like I said, episiotomy or operative vaginal delivery. And they say, according to the fetal factors, they say that, premature fetus is at a higher risk, because obviously the immune system will be weaker already. Invasive fetal monitoring, like, fetal scalp electrodes or fetal scalp, sampling, umbilical blood samplings, you'll be giving it more exposure to the mother's secretions, right? Or, PPROM, prolonged exposure to mother's secretions, long labor, very, very important, and breastfed infants. So these are the risk factors which increase the vertical transmission from the mother to the child. A word more about it. So vertical rate usually is around 30%, and various risk factors increase the perinatal transmission, which we just started. Viral load and perinatal transmission, they are directly related. We just saw that. 23% of vertical transmission is there with a maternal load of more than 30,000 copies, but only 10% with maternal load of less than 400 copies. So if you have got lesser load, the transmission will be less. Okay, and this is going to be the statistics, if you can remember. But most of the transmission occurs in labor, so you have to be very gentle, very, very no-touch technique kind of a person during labor. Okay, but if you start using good amount of antiretroviral drugs, if you avoid doing those needling procedures, if you avoid doing invasive monitoring, and if you go ahead with elective cesarean delivery, very, very important, because that's a question that can be asked even in your Viva. What about elective cesarean delivery for an HIV positive female? Treatment of neonate with antiretroviral therapy, very, very good. Avoidance of breastfeeding. These are all those ways in which you can decrease the vertical transmission. And in India, we have this PPTCT or mother-to-child, this transmission program, that MPCT program, which was the guidelines of which were published in 2013. And they have seen a very huge reduction, right? From 35% to less than 5% in breastfed infants, and 25% to less than 2% in non-breastfed infants. So it's just a 5 or 2%, decrease. So you might as well go ahead and do. See, if you ask whether an HIV patient should breastfeed the infant, ideally no, but there are more benefits to risk. That is why it should be allowed along with ARV. That is going to be your answer. Okay, there is no second opinion about it. You've said everything. That's the way your answers should be, even in your Vivas. Now, can you imagine what would be the effect of pregnancy on HIV? Does it do anything? What will it do to the virus? It's already a very smart virus, right? So it does not have any adverse effect on the natural history of HIV. It continues as it is. But I think I would say it continues even faster, because pregnancy is already an immunosuppressed condition, right? But HIV, for our own benefit, is non-teratogenic. Up till now, there have been no reported teratogenic effects of HIV, and as a result of which we do not say that it's going to directly harm, but yes, it's definitely going to infect the child, for which we have to be very, very careful antepartum, especially intrapartum, and then postpartum to the baby. So we're going to touch upon all these important parts, because that is the thing which is going to be expected out of you as a postgraduate for HIV in pregnancy. In fact, these things have been asked multiple times in your exams, right? So what are the effects of HIV on pregnancy? How does HIV influence the pregnancy? So, well, maternal mortality, morbidity rates are not increased in seropositive asymptomatic women. And if properly treated, there is no increased incidence of abortions or preterm labor or fetal growth restriction or perinatal mortality. However, if it's not properly treated, the patient has not been compliant, the CD4 cell count is more, especially in developing countries with symptomatic and advanced disease. Then very bad outcomes, perinatal morbidity, mortality, preterm labor, FGR, everything is seen. Okay, that's going to be your answer. Now let's start from before she's pregnant. Pre-conceptual counseling for a patient who's come to you for, maybe she is living with an HIV positive partner, or she's also turned recently HIV positive and now she's planning for conception. Well, every female should have HIV testing, all those who are in the childbearing age group. There is a routine testing, that we've been doing it from a long, long time. Screening is done by which method? Okay, guys, come on. Though you've seen it already, but quickly write down. Screening is done by which method and confirmation is done by which method? Come on, wake up, guys. Let's be a little more interactive. So, can you tell me that screening test? What test do we do, and what is the confirmatory test of HIV? I expect this from you, and you have to be quick in answering this. So, I'm waiting for your answers. Let's see who answers first. So okay, guys, come on. Where are my favorites? All my favorite students, are they there or not? Those who always answer. I want them to answer again. Great, great, great. I'm seeing few comments. Yes. Great. One, yeah, ELISA, definitely. ELISA is your screening test, correct. What is your confirmatory test for HIV? So what we do in low resource setting is that we do an easy test, or let's say a cost effective test. Very good, Aruna. That's great. That's great. I've already got my answer. You have the screening test is the ELISA and the confirmatory test is the Western blot. Now my second question. ELISA is based on which principle and Western blot is based on which principle? That means, in short, what does ELISA detect? Okay, is it the antigen, or is it the antibody, or is it the viral RNA? And what does the Western blot detect? Okay, you have to tell me these two answers. Yes, antibody by ELISA. Excellent, Aruna. That's very good. Antibody, yes. So ELISA test and all the rapid tests, even those HIV kits, that you've seen, must have seen many people just attach it on the patient's performance sheet or the prescription or the test where you write down you do this HIV test. Some of them they attach it there. That they are all, those rapid tests are all antibody testing for HIV. Okay, now these antibodies, remember how long they take to come? 3 months or more, right? An antigen test, they are not that inexpensive that you keep doing in our low resource setting. So we do the ELISA test and we do the screening test by ELISA. That means we are detecting the antibody. What about Western blot? Yes, I think some students are very smart, very, very smart. What about the others? I am sure you all know the answer. I just want you all to give the answers. Come on, guys. And I was very happy today when I saw my students interacting with each other. I like that. Okay, some of you can post the questions, the other can answer. There's a good bonding. You can easily go ahead doing that in the chat. It's very good to see that. A very, very informative, chat system by answering each other. All right. So the Western blot, it actually detects the viral RNA. It's somewhat like your, PCR kind of a thing, or the NAT kind of a thing, right? So what it does is it detects directly the HIV RNA. Okay. So how do we counsel this patient? We counsel the patient that we find you're HIV positive, we'll confirm it. Then we'll go ahead doing your CD4 cell count. Then you can plan a pregnancy. If the CD4 cell count is at a respectable level, you have to continue your ARV throughout your pregnancy. Even after that, even if you plan the next pregnancy, you will not stop it in between. You'll have to have more antenatal visits. If you're ready for all these things, you need to have a support system at home. Even after the delivery of the baby, we'll try to reduce the risk of transmission. But immediately after the baby is born, the baby will have its own set of tests and will have its own, follow-up accordingly. If you're ready for all these things, go ahead and plan a pregnancy. Okay, we put her on high dose folic acid and we give her, review her ARVs. are antiretroviral drugs. I have immensely incorporated those charts which you need to know for ARV, and proceed from there. As far as the clinical presentation of AIDS is concerned, when they do have a very full-blown AIDS, it is catastrophic. It's very easy to catch. But other than that, they have very non-specific symptoms, like, a feeling of malaise, a feeling of lethargy, not okay, a low-grade fever, or even high-grade fever with chills, very on and off, getting sick again and again, headache, weight loss, okay, decreased appetite, mouth ulcers again and again. They are all signs and symptoms which have to be taken seriously. So here is that part which I wanted to discuss with you. You have ELISA, the enzyme-linked immunosorbent assay, which screens the HIV antibodies. They have not spoken about the antigen because there is only a couple of tests like GP24 antigen, which has recently come up. I won't say recent, but it's old in the sense, but at the same time not so much incorporated, especially in our low resource settings. That much we rely more on the sensitive, highly sensitive ELISA test. This is the problem. We need to. The test is not only sufficient. The performance of the test is very, very important. How sensitive the test is, how specific the test is. So Western blot becomes the confirmatory test because it's very high in specificity. Okay. When you're talking about antibodies, it becomes very, the ELISA test becomes the most important screening test because it's very, very sensitive. Okay, so rapid tests, ELISA tests, they all depend to detect the antibody of the HIV virus. And the test algorithm now used by National AIDS Control Organization, the NACO, which I've been talking right from the beginning about, it recommends 3 tests. Okay, it recommends 3 tests. If all the 3 are positive, it is obviously HIV positive. If 2 are negative, that means only 1 is positive, we call it HIV negative. But if there is, one negative and 2 positive, we call it equivocal, and there we try to go ahead with confirmatory test by Western blot. Now the Western blot test, or the immunofluorescence assay, or the HIV NAT test as we call it, is highly specific test but little expensive, so we require it and we reserve it only for those conditions in which HIV has come out to be positive. And according to NACO, we do the 3 important tests. That means 2 rapid tests and 1 ELISA test, mostly to detect whether this patient is HIV positive or negative. So this is nothing but a staging system, most of which we've already spoken about. What happens in stage 1, what happens in stage 2, what happens in stage 3. So if you want, you can just take a picture of this and we go ahead, because there is nothing much to explain. As you see, we are going from stage 1 to 4. We see that one, she was asymptomatic before, then she started having some very mild infections in between, like angular cheilitis, or seborrheic dermatitis, or recurrent oral ulcerations. And then she goes on to stage 3, where she starts losing the body weight. There is persistent diarrhea, persistent fever, oral candidiasis, recurrent mouth ulcers. She develops pulmonary tuberculosis, and seeing that I included TB in pregnancy along with it. If I do get time, I'll probably take that up as well. And many bacterial infections, very bad infections like pneumonia or empyema or meningitis or joint infections, and ulcerative stomatitis, gingivitis, a lot of GI tract goes bad. And stage 4 in which there's HIV wasting syndrome, the full-blown AIDS. Here's where Pneumocystis jirovecii, we used to call it Carinae before, and jirovecii, pneumonia comes up. All the bad infections, very difficult to treat infections, they come up. You have cryptococcal meningitis, or HIV encephalopathy, or recurrent septicemia by CMV, and it's a very, very bad phase to treat.